So we're going to start with a didactic session on spirometry abnormalities in sickle cell disease. And it's Dr. Catanzaro, is that how you say it?
Yes.
Okay, perfect. So our speaker today is currently Associate Professor in Pediatric Pulmonology, practicing in East Carolina, has been there since 2023, and has interest in sickle cell disease and cystic fibrosis. Previously, spent a lot of time in both Florida and Wisconsin, at Nemours Children's Health in Jacksonville and Children's Wisconsin. As I said, she is a pediatric pulmonologist, and we are very excited, again, as somebody who does organ dysfunction, who dabbles in other people's subspecialty. It's great when we have those from the specialty come and talk to us directly about their expertise in pulmonary disease. So we look forward to the talk. Thank you.
Thank you. So thank you for that introduction and for inviting me to speak. This is my first time attending this, so I was a little bit unsure of the audience, and so I hope that at least you take some information to apply to patients moving forward. In this short time, I was kind of thinking, what would I tackle? So, there's a lot to talk about in pulmonary complications in sickle cell. But I decided to kind of focus a little bit more on lower airway disease and spirometry. As Sonia mentioned, I don't have any disclosures. And then the objectives for my talk are to, for the participant to be able to recognize the prevalence and burden of lower airway disease in sickle cell, and then to describe some of the spirometry findings in children and adults with sickle cell disease, and finally to identify patients for pulmonary referral and pulmonary function testing. Just sort of on a personal note, I think what I've enjoyed is kind of doing some of these multidisciplinary clinics where we try and capture both the patients during their hematology visits, as well as seeing them on the pulmonary side, because definitely pulmonary complications in sickle cell disease carry a high burden. Patients are already dealing with a chronic illness, and we are kind of adding on this extra system involvement. I think too, when I was looking, reviewing for this presentation, it's kind of a struggle because I feel like we have more questions than answers over time. And so there's still a lot that we don't know. So the pulmonary complications often begin in childhood, with frequent admissions, and can be as early as, a year old with, recurrent acute chest. And all of these are associated with higher morbidity and mortality. So more severe disease course, and then death most commonly occurring in the context of acute chest syndrome, pulmonary embolism, and or pulmonary hypertension. When we think about the pulmonary complications, I kind of touched on, acute chest syndrome. And we may think of that as, the most obvious thing because that's bringing them to the hospital in acute care, and needing respiratory support, antibiotics, and complicating their pain crisis. But there's also other things to consider that are more chronic, and perhaps those are even more debilitating and weighing on their families. So lower airway disease and abnormal pulmonary function, how is that affecting their day-to-day in terms of respiratory symptoms? Also sleep disordered breathing, obstructive sleep apnea, we know is also prominent in this population. And then pulmonary vascular complications, such as pulmonary hypertension. So in terms of lower airway disease and sickle cell, it's definitely complicated because there is so much overlap, right, between what are their respiratory symptoms. Are they having pneumonias in early childhood, vaso-occlusive crisis and acute chest, or can they also have this comorbid asthma kind of overlapping? And I think sometimes it can be missed, or it might not be the priority that the family is bringing to everyone's attention. But we do know, at least from what we're able to estimate, that the prevalence of physician-diagnosed asthma among children with sickle cell is approximately 25%. And there's probably many more patients that are having either isolated recurrent wheezing or airway hyperresponsiveness that may not meet the diagnostic criteria, or maybe their family doesn't really acknowledge it or notice it because they're focused on, their pain crises. And then I think the key thing is that childhood asthma is associated with more frequent vaso-occlusive events, earlier onset of acute chest, and then, recurrent acute chest and mortality. This kind of, going back, this is obviously from the cooperative study of sickle cell disease back in 1985. So this is before hydroxyurea, but it's something that, we quote and look at a lot in terms of what is our understanding of pulmonary function testing in patients with sickle cell. And that study kind of, showed us that the major abnormality was a mild restrictive pulmonary defect. The other thing that kind of came out is that, the spirometry early on may be within the normal limits, but then the question is, is it at the lower compared to the population? So are we looking for something decreased compared to population, or, abnormal and, in general? I think this is probably going to change now that we have, new guidelines for predictive values. And so, hopefully we'll get a better understanding moving forward. So in terms of lung function in patients with sickle cell, what do we know? So we know that children have a reduced lung function compared with control subjects, but many are still within the normal range. And that's where it becomes really critical, right, to be vigilant, to pick up on those patients who have predisposing, factors for things like asthma, whether it's a family history, allergic sensitization, or signs of hyperresponsiveness. And then about 15 to 20% of children and adolescents will have obstructive physiology. And that, how are we going to get at that, right? So we sort of need to be screening and vigilant, referring them. And then a higher prevalence of lower airway obstruction, up to 57% more, and airway hyperreactivity in children with sickle cell disease. So that's where, we're able to look at pulmonary function testing and maybe do some challenge testing, either giving them a bronchodilator and looking for hyperresponsiveness, or, even challenge testing like methacholine challenge. And then it's thought that by adulthood, many individuals will meet criteria for restrictive lung disease. And that, is thought to be due to the repeated episodes of acute chest and, leading to sickle cell chronic lung disease. These are sort of something that was put out in terms of what are the patterns of lung function that we can see in patients with sickle cell. And we really focus on, what is their FEV1 to FVC ratio, right? So how are they able to get air out of their breathing tubes? And is that obstructive? Is it low? More suggesting that maybe they do have a restrictive component. And so to sort of get at this, you do need plethysmography, which isn't always as feasible, but spirometry is, and I'm going to go over that a little bit more later on. But basically, we can see all of these patterns, and really, because we lack studies in terms of prospectively looking at lung function, it's hard to know if we're seeing population, within sickle cell disease, that this is a trajectory, from childhood to adolescence to adulthood, or is it a specific subset of the population that is having these changes in lung function over time? So, it's still a lot of open, ended questions, because much of the information that we have is based on small retrospective studies. So a lot of the questions that remain, like I touched on, are what is the evolution of lung function across a lifespan? What is the clinical significance of these abnormalities? So, should we be screening everyone to kind of understand, what happens with lung function, or should we be selecting patients based on certain factors? And then, like I was mentioning, it's really unclear, is this obstructive defect something we're picking up in children that are, have comorbid asthma, or, is this repeated obstruction what's leading to their restrictive defects in the future? So kind of looking at what's recommended, this is from the National Alliance of Sickle Cell Centers consensus. And basically what they said was, in terms of pulmonary complications in sickle cell disease, they recommended screening all children 2 to 18 years of age for hypoxemia at baseline, symptom screening for obstructive sleep apnea, and symptom screening for asthma. And I think we all kind of know that the symptom screening can kind of be hard, right? Are we relying on the parents to come to us and saying, like, these are the symptoms that my patient has or my child has, or do we really have to dig deeper? And I think even sometimes when they come to my clinic, for a referral from their hematologist, they often don't know why they're there. It's just another doctor. And so I feel like we really have to hone in on, what symptoms they're having, because they don't acknowledge it. For example, snoring, a lot of times we ask about that and everyone just laughs because they kind of accept that as normal. Everyone in the household snores. They don't realize that that's a problem. So I think we have to first acknowledge that they're not going to come to us per se with these complaints. I often also hear parents say, well, he gets tired when he exercises, but it's really hard for them to know, is that fatigue or pain related to their sickle cell disease, or is that asthma? Is that, a respiratory component that's really limiting them? And so I think, at least in those initial visits, a lot of it is kind of asking them those specific questions because they won't voluntarily, bring that up. And then interestingly, so screening with pulmonary function testing is not recommended. Instead, they kind of propose, who are the patients that should have PFTs and when should they be referred. So, it's going to be a referral to pulmonary for the pulmonary function testing. And these are, some of the things that should prompt that. So if they're having oxygen saturation that's less than 95% at rest, if they do have history of acute chest syndrome, if they've had reported wheezing, nighttime cough, syncope, dyspnea, any history of pulmonary embolism, or history of recurrent vaso-occlusive episodes. So pulmonary function testing, I think we could probably do hours-long testing on, what can we look at. So there are things, including spirometry, plethysmography, diffusion capacity. There are 6-minute walk tests, and then you can think of further workup, CAT scans, and other evaluations, but probably the easiest and most feasible thing is spirometry. So that's what I'm gonna spend some more time talking about. So pulmonary function testing is a key part of my practice as a pulmonologist, and so we're very happy when we have this kind of objective information, right? Because I just went over all of the pitfalls of that kid showing up in your clinic and maybe the parent doesn't even know why they're there, and can't really give you a good symptom history. So pulmonary function testing is crucial to diagnosing specific disorders. So we can look for obstructive defects and reversibility that would confirm asthma, restrictive lung disease. So if we're seeing changes in specifically more plethysmography, but spirometry can be suggestive of that. And also chronic obstructive pulmonary disease. It's also a great tool for us because we can actually, trend something over time. And so if we do implement a medical therapy, and bring them back, do we see things getting better? Do we see things getting worse? What is the disease progression? This is especially true for children because I've had many come and they think it's a great day and they're breathing fine. And then we do a breathing test and we pick up on obstruction that they've just lived with their whole life. And so they've really become used to that. And so they can't even, tell you that they're having trouble until they're really decompensating. So it does help us with that assessment and then, helping with prognosis. I think too, for, I take care of pediatric patients. So But for parents, to see a number that this is abnormal kind of puts things into perspective for them, and maybe they'll pay, closer attention or be more diligent in terms of, following up with medications and care. And then there also usefulness in preoperative assessments. I'm not sure how much that plays into the adult world, but there are times that I've been asked for clearance from a pulmonary standpoint, and so it's nice, at least before they're undergoing anesthesia, that we know that their lung function is normal beforehand. So it can be useful in stratifying patients in terms of risk, and it's a useful tool. So basically for spirometry, we are just measuring, what's the volume of air that they can exhale as a function of time. And it's pretty simple. Like you can see in this kid, it's probably one of the easier tests or things that our patients with sickle cell have to undergo. Basically, they're just going to exhale into that tube, and we're going to be measuring what they exhale. This is kind of a graph here, just showing for different defects. So over time, so with normal in that first second, we're going to get out at least 80–85% of our air in that first second. But as you can see, with obstructive disease, that's going to be lower. And so they may eventually exhale that same amount of volume. It's going to just take a longer time for them to do so. And then for restrictive lung disease, they're going to exhale, proportionately to what they have, but overall their forced vital capacity is lower in terms of what their total exhaled volume is. These are just some basic defects. I know, as a hematologist, you're not going to be looking at these, but just kind of looking at the patterns of their expiratory flow volume curve. So in obstructive lung disease, it's going to be this kind of scooped out shape, and then for severe obstruction, it's going to be even more so. Whereas with restrictive, it's going to look similar to normal. It's just going to be a reduced volume. So the advantages of spirometry is it's pretty safe, quick and inexpensive. So they can come to our clinic, and we do them routinely at most visits. There are a few contraindications, such as pneumothorax or if they had recent surgeries, but otherwise, or acute pulmonary hemorrhage. But for the most part, it's a safe study. As I mentioned earlier, we can follow it longitudinally. So that's kind of a feedback. I think whenever we can give a medication or use an intervention and then follow what happens over time, that's going to help, both patients and parents to sort of buy into that therapy. And then spirometry does, correlate strongly with morbidity and life expectancy. So if we are seeing chronic changes and progression over time, that's going to be important cue for us. And as I mentioned earlier, we may be able to pick up on things that are subclinical or that parents aren't recognizing or the child isn't. Some of the limitations, especially at young age, is that it is highly effort dependent. So they do have to cooperate for it. In our clinic, we routinely do it, starting around 4 or 5 years of age, and probably more reproducible data, closer to 6 years of age. But then moving forward, they usually get better at that technique and we're able to follow it. The other thing is that sometimes, you can't just rely on that single testing session, like I mentioned, and you do have to put it into perspective, what else might be going on with them clinically. So then just looking at this study of the effects of hydroxyurea therapy on pulmonary function testing and McLaurin. So this was a retrospective analysis of 56 children and adolescents with sickle cell age 5 and above. And they carried out longitudinal lung function testing from 2000 to 2011. And they were able to see that after starting hydroxyurea, the annual rate of decline in FEV1 was less pronounced in the study group than in the patients who didn't receive this therapy. And I often use like my visits, not even just to, focus on the pulmonary manifestations, but also just reminding them. I feel like sometimes I'm just another provider saying, are you taking your hydroxyurea, especially for those with the recurrent chest episodes. And so again, having a number and having something to show them that, this is your lung function, this is why it's important, and it's going to help is useful. And then there isn't so much, again, like I pointed out, we just lack a lot of studies specifically looking at lung function in sickle cell disease. And so the use of inhaled bronchodilators, nebulized albuterol, or ipratropium, oral prednisone can definitely be at times controversial, but they strongly recommend not withholding it, especially in a patient having an acute exacerbation with wheezing and hypoxemia. Liberal use of inhaled steroids is recommended, considering leukotriene inhibitors such as Singulair, and then having a low threshold to admit mild exacerbations because they are at high risk for associated complications. And then close monitoring and follow-up. So that's where I think it's been helpful for myself when I'm consulted inpatient and I can see a patient during their acute chest episode and then sort of follow up with them, because oftentimes
Yeah, it's harder on Zoom now, realizing if she paused or we paused, but it seems like she was paused and then oh, here we go. All right, welcome back. You're just on mute still, but
sorry about that. And go back real quick. I don't know, is it still sharing? Is that still sharing?
Not yet.
No.
Sorry, I'm not able to get back to that. Can you all still hear me?
Yes, we can.
Yes, we can hear you.
I'm sorry, I don't know why I can't get back to that screen, but for the take-home points, I just really wanted to stress being vigilant in screening and treating patients for chronic respiratory symptoms, because it's definitely something that can kind of get wrapped in with all of the other complications of their sickle cell disease. And spirometry is safe, it's easy, we can do it in young children. We can give some objective feedback from interventions and provide a periodic assessment to make sure that we're mitigating whatever we can in terms of disease progression. And then spirometry also can be useful for risk assessment, like we talked about with preoperative stratification, and then also, intensifying therapy. And then I know I said it probably multiple times during the presentation, but there is a lack of controlled trials in patients with sickle cell disease. And little is still known about lung function and the effects that asthma treatment has on this population.
Can I ask a couple of questions? This is Dr. Raj. So thank you for the presentation. But what's the role of iOS? At one time, it was considered a trendy and promising tool, especially in younger children. That's one question. The second was, there had been some preclinical trials done by Poonam Malik from Cincinnati, which showed that there was augmentation of the leukotriene pathway related to hemolysis in the patients. I didn't follow up that science, how it evolved. And I used to prescribe a lot of Singular, but my concern was that about its side effects with behavioral problems and other things. So whether we should be prescribing more or less, that's where I'm sort of waffling on that. So if you can share some thoughts on that.
Sure. I mean, I think in terms of incentive spirometry, actually, I didn't present it in this, but I had read a paper on it. I mean, and actually they did present some interesting stuff on that. I mean, overall, with the risks of atelectasis and pain contributing to their, poor inspiratory effort, I've still always recommended it during their acute episodes inpatient. And then I know also, there aren't retrospective studies on it, but throughout my fellowship, we often would have patients more frequently on nebulized treatments rather than inhalers with MDIs. And, patients symptomatically report a lot more relief from that. And I think that has to do with, their inspiratory, effort, for lack of a better word, during crisis and with splinting. In terms of Singular, I still feel like it's very variable. I mean, I think we ask a lot about it. I definitely feel it's certain patients that it's helpful because it's, chewable, easy, and they don't have to worry about their technique. So I'm often not shy about starting it, but I keep reassessing whether or not it's helping them. And if they do have any behavioral side effects from it, I discontinue it. And I haven't had any patients that have had prolonged adverse side effects from that.
And I'll just put a plug in for all the pulmonologists who are joining today. When we did the cardiopulmonary renal guidelines, part of the issue is these were evidence-based, and there's not enough research out there on whether or not an abnormal PFT in somebody who's asymptomatic led to any outcomes. And so in the absence of evidence, then it was a suggestion against performing it. And so again, the more data that pulmonologists can add to the field in terms of the benefit of screening and how screening can lead to interventions to improve outcomes, it could change potentially that recommendation should ASH decide to redo it. And there's one question in the chat, and then we'll move to the case presentation.
Hi, this is Yogi from St. Jude. I was wondering if you can comment on the role for the monoclonal antibodies, so the interleukin-4 antibodies in asthma, and if we as hematologists should monitor CBC frequently while concurrently on hydroxyurea.
I'm not really familiar with, following that closely. So I'm not sure to answer that question. I know I did pull up a few papers where they are trying to get at that, definitely in terms of what are the inflammatory markers and trending that, but I haven't, read on that specifically. I don't know if anyone else that has.
Yeah, I can chime in. So I think one of the struggles that we have, and thank you so much for the presentation. That was very, very helpful for everybody. One of the struggles that we have is if a patient with sickle cell disease have obstructive airway disease, is that like, are all sickle patients with obstructive lung disease of the lung function are the same, or there are like sub-phenotypes within this category? And as you may also have noticed that There are different phenotypes in patients with sickle who have obstructive lung disease. Some of them, they have atopic phenotype, which is asthma phenotype, which is reversible kind of obstruction, just like other asthma patients. And those patients can have a high IgE level, high eosinophil, just like any asthma in general population. And what we usually do is we do a couple of things. We do a pre and post bronchodilator for those patients just to identify which one of them have reversible airway obstruction versus fixed airway obstruction, which can be part of the sickle cell lung disease that causes fixed airway obstruction because of the inflammation on the airways rather than like typical asthma. And then sometimes I also do FeNO, which is exhaled nitric oxide, because this also will increase if you have atopic kind of asthma. So to answer the question, what we usually do, we have a lot of CBCs usually in those patients, so we look at the eosinophil level. I send specific IgE level, which is the RAS test, just to look at the level of IgE, and there is a specific allergies that those patients have. And together with the FeNO, we can kind of categorize them into atopic or asthma phenotype versus sickle cell lung disease, which causes also obstructive airway disease. Because for the asthma patients, they typically respond very well to the asthma treatment. Inhaled steroids, combined therapy, even monoclonal antibodies. And we have a lot of patients who are on monoclonal antibodies that responded very well to them if they have they meet the criteria for those monoclonal antibodies. But the other group of patients that we usually struggle with managing, which are the patient with fixed airway obstruction, especially if it's complicated by recurrent acute chest syndrome or chronic hypoxia, pulmonary hypertension. This is the group of patients that we usually struggle managing because they don't typically respond to the typical asthma treatment, and they may respond better to the specific sickle cell therapies. So if they have a comorbid condition, sometimes controlling their obstructive sleep apnea or controlling their hypoxia or starting them on hydroxyurea or one of the new therapies will improve their kind of obstructive airway disease and slow down the decline. But this is all anecdotal kind of data. As Dr. Liebensberger mentioned, and you mentioned in your presentation, we need to do more kind of research to confirm or decline those kind of observations that we have in the clinics. But I think if we don't do these kind of studies, then who will do these kind of studies? So this is my own point of view about those patients with asthma and how we manage them in our clinics. But maybe other people have different kinds of experiences.
Okay. All right, fantastic job. Thank you so much. And again, we appreciate all the new pulmonologists who joined. And we'll move on now to the case presentation. And thank you for being able to join us today. Dr. Raj, you want to introduce?
Yeah, thank you all. I know it's a great presentation, and we have a very interesting case as well. So all the pulmonologists, please stand by. So our presenter today is Dr. Tiffany Brooks. She's a second-year resident at Norton Children's Hospital. She received her BS from University of Cincinnati, and she's a graduate of Ohio State University College of Medicine. Dr. Brooks is interested in hematology and oncology and is planning to apply for fellowship this cycle. And her interest includes clinical research, but right now she's leaning towards solid tumors and AYA population. But hopefully we can also kindle her interest in sickle cell disease. So Dr. Brooks, could you take it away?
Everyone see my screen?
Yeah, we can see the screen. Yeah.
Okay.
You can increase the volume a bit, Tiffany, if you can.
Oh, yeah, it's really better now.
It's a little muffled, the volume. Yeah, still muffled.
1 second. All right,
It sounds real robot-y. Is it possible that something's not plugged in all the way, or you could call in?
Yes, and I can just call it. Sorry, I'm technical difficulty.
The share screen went away, Tiffany.
All right, can you hear me now?
Yes,
Okay. All right.
but we need that. You may want to mute your
Oh,
computer and then
how about now?
share the screen again. We don't see the presentation. Yeah, we're good. You're muted. Yeah, increase the volume a bit more. The volume is low on the phone.
Am I echoing?
You are. Can you disconnect the audio from the computer so that you only have the phone audio? At the bottom where the far left where the microphone is, that caret, where it says to
How about
switch to
now?
phone audio. There you go.
There we go. Okay. And then can you guys see my screen?
Yeah, and you can go to display settings and switch to presenter, switch to screen.
Okay, let me switch that.
It's good.
So I will be presenting on a patient, a 5-year-old with sickle cell anemia, hemoglobin SS, who presented with 2 days of cough and fever and increased work of breathing. Other associated symptoms include chest and abdominal pain. Oops. My goodness. All right, I want to reshare it. Okay. Other symptoms included chest and abdominal pain and headache. So some case background, the patient was up to date on their vaccines with the exception of COVID and flu. Home medications included hydroxyurea. Prior to this kiddo was relatively healthy, had one pain crisis at 12 months of age, and one former ED visit for pain crises at 3 years of age. So upon presentation, temperature was, she was afebrile, 97.8, heart rate was 167 with a respiratory rate of 37. She was tachypnic and she was sitting at 100%, but her blood pressure was soft with 65/26. So on physical exam, she was alert, had scleral icterus, and had diminished breath sounds, predominantly on the left side, and was mildly tachypnic without retractions. She did have delayed cap refill. Her abdomen was nice and soft, but and non-tender. Splenomegaly was appreciated, and there was significant jaundice. From a neuro standpoint, she was not altered. She was answering questions appropriately. So in the ED, she received several LR boluses and was started on an epi drip. She was also placed on a non-rebreather. She, due to low blood pressures too, she received 5 mils per kg of a transfusion. For her pain, she received Tylenol and ketamine, and she was admitted to the PICU for concerns for septic shock. So initial labs, her white blood cell count was elevated at 39.7. Hemoglobin was 5.4. Her pH was at 7.28. Her Billy was also elevated at 19, and her bicarb on CMP was 15, but on CBG was 17. Her retic count was 6.5. So imaging initially included chest x-ray, which showed a left lower lobe pneumonia, and her abdominal x-ray was read as normal with no acute concerns for an obstruction. So upon admission to the PICU, she rapidly progressed and was intubated. And next they got a CT, which showed the extent of her pneumonia. A chest tube was placed. And I'll kind of get to what grew a little bit later on. So she was placed on ECMO. She received epi, not norepi vasopressin, but still was declining. So she was placed on VA ECMO. Initial EKG was concerning for pericarditis, and they also got an echo, which showed decreased LV systolic function and dilation. It was presumed that the LV dilation was most likely secondary to her longstanding anemia and was worsened in the setting of acute illness. And so the reason why we thought this case was also interesting is ECMO and the relationship with sickle cell. There are 2 types of ECMO, VA and VV. VA is more what they consider like a cardiac ECMO, where the machine runs in parallel to the heart, whereas VV ECMO is what some PICU attendings say as like lung ECMO, where it kind of helps protect the lungs. So the reason why this is interesting, the studies that I have found, it's very limited in ECMO use in sickle cell. One study that I saw, which was pretty limited, but found that compared to the normal population, 20% of sickle cell patients survive off of ECMO versus the general population is around 50 to 60%. Another article also went into common complications with ECMO, including cerebral infarct and hemorrhage in the setting of sickle cell patients. And another study also found that the survival rate was a little bit higher, with 52% of pediatric patients surviving off of ECMO, but it did vary in outcomes in terms of whether VV versus VA ECMO was used. And in our case, VA ECMO was used in our patient. So cardiac and respiratory complications continued. She did have some difficulties on the vent, so surgery and POEM were consulted, and it was found that she had a very large mucus plug. She eventually was able to be weaned to high flow nasal cannula, and eventually to room air with the chest tube being pulled. So in terms of complications from her ECMO, she was found to have an occlusion of her right IJ, and it was initially thought that it would be permanently occluded. Repeat ultrasound did show that greater than 50% were stenosed. At that time, PT and PTT were elevated, and she was started on Xarelto. Of note, during her admission, her hydroxyurea were held, and in terms of anticoag, she received TPA while the chest tube was in place. So her plan was to continue on the Xarelto for about 6 weeks. However, imaging after 3 months continued to show occlusion, and her most recent ultrasound, which is now about 6 months out, still showed occlusion, so she continues to be on Xarelto. So in regards to infection, so her pleural effusion did grow group A strep, EBV and CMV were also positive. Enteroparavirus and HSV6 and adeno were all negative. In terms of her kind of antibiotic course, she initially received vancomycin in the ED and then was started on azithromycin. All of the blood cultures that we obtained were all pre-treated. And then once she was placed on ECMO, she was brought into cefepime before being transitioned back to Rocephin. So another reason why we thought this case was interesting is because typically in sickle cell, strep pneumonia is the most frequent cause of bacteremia. At baseline, sickle cell patients do have some increased risk for infection from functional asplenia to deficiencies in some of their neutrophil functions. So it typically we will, in my research, I haven't been seeing a lot of cases that where they grow group A strep that leads to this type of shock picture. Other complications for this kiddo included hyperbiliruria. She did get a CT, which did show a thickened gallbladder. It was thought by GI that's most likely her hyperbili was related to her severe sepsis. She was briefly on Uridile and her bilirubin improved. And on admission, she did have a AKI. This was also thought to be secondary to dehydration and the acute illness. It's also unclear if part of her AKI was at one point worsened by the ECMO, as I've read in literature that can also be a contributing factor. But once she got out of the very acute illness period with maintenance IV fluids, and she was eventually able to return to her baseline and the AKI resolved. So in regards to outpatient, she was discharged to inpatient rehab. She had a very brief stay there. And now about 6 months later, she's 100% at her baseline. I believe she is now in either pre-K or in kindergarten, and parents attest that she's doing well. She's not had any further pain crises or visits to the emergency room. So the takeaway points that we want to highlight this case included that there's very limited research with ECMO and sickle cell patients, especially in the pediatric population, and the overall survival is decreased compared to the general population, and that there are some risk and potential serious complications that should be monitored throughout the patient's course. One thing I forgot to mention is that this kiddo did get a CT head scan during the process, which showed no acute findings, but it's something just to keep in mind when a kid is on ECMO. And the other thing that also highlights in this case is that group A strep bacteremia or primary driver for a sepsis picture is also rarely seen in this population, but it does occur.
Thank you, Tiffany. Just a few things to add. As Tiffany presented, so the initial vital signs seemed good, but she had a really rapid deterioration in the ED setting, which led to her going to the PICU, and within 2 hours, I think she was on ECMO. And about the same time, unfortunately, I lost a close friend's daughter, adult daughter who died of group A strep infection, and she went to a hospital, but there was no ECMO. So this child was in the right setting, so we could immediately use this wonderful treatment that's available to us, and she survived this. There has been, I'm sure you've also seen more virulence with group A strep post-COVID, and there's been reports of that also in the literature. And especially there has been an uptake in 2023 compared to the previous year for group A strep, and very severe infections have been noted. But this is, in my career, this is the first time I saw such overwhelming group A strep sepsis in sickle cell disease. So very interesting presentation, I thought. But we haven't done anything in terms of long-term management, just continued hydroxyurea. We didn't put the patient on exchange transfusion or anything, because she's been doing well after that. I think I was planning to get an echo just to make sure she has not had any pulmonary hypertension as a result of this severe episode. And also some PFTs also, which we should do after today's presentation. So that's all my comments. If you have any questions, we would like to hear from you.
I have a couple questions and one comment. Question number one, was the patient on penicillin prophylaxis? Was the patient taking penicillin before this episode or not?
I'm trying to remember. How old was she, Tiffany?
She just turned 5, so she was not on.
She was getting penicillin, but there has been, I'll give this to you. There had been a patient where we have some language barrier issues, and there has been adherence to the clinic and appointments prior to this. So penicillin was prescribed to her, but whether she took it or not, family did say that they were giving it to her, but there had been a lot of missed appointments prior to this.
Yeah, because we don't know how much, like if she was taking penicillin regularly, if this could have prevented.
Yeah.
Because I'm looking at the literature, and there are a few reported cases of group A strep in sickle patients, and they mentioned that for 2 of them that they were on penicillin before they got the strep bacteremia and septicemia. So as you mentioned, there may be some like more predisposition to group A following the COVID, or there's more resistance to penicillin. That's why I wanted to see if we need to change the prophylaxis to something else, if she developed the infection while on penicillin. Question number two, she got vancomycin in the ED. Did she get also ceftriaxone, Rocephin also?
Yeah, ceftriaxone, azithromycin, and vancomycin. Also.
Yes, okay, just make sure, because in the presentation it was not clear. Just make sure that we cover the gram negatives. And the one comment is about group A strep pneumonia. We see it in patients without any underlying conditions, and it's called flesh-eating pneumonia. The very important characteristic of it is very rapidly progressive. So if you don't catch it early on, it can like start eating up the lung. It's very fast. Like if you repeat the X-ray in half an hour, you see the different change in the X-ray. However, most of the patients that we treat, if not all, the bacteria is very susceptible to the antibiotics, even the simplest antibiotics that we need to use. So the key thing is to start any antibiotic, especially penicillins or cephalosporins, as soon as possible. The sooner you start antibiotics and the good dose that you give, the sooner the patient will improve. But they can progress like really fast, that they can lose most of their lungs and be on ECMO for a long time. Even we had patients who went home on event because their lungs were so damaged because they presented late into the hospital. So we see it in different settings, but I agree with Dr. Raj that we didn't see a lot of sickle patients with group A strep pneumonia. So this is I think it's a reportable case. We can probably work on it, Tiffany.
Thank you.
for the next
One
few
one
months.
more point. Thank you for that wonderful comments. One more point I wanted to ask, as far as the increased incidence of strep in patients nowadays, we're also become sort of hypersensitive, right? Since 2022, 2023, because whenever there was respiratory symptoms, we got COVID and strep testing a lot more than we were doing previously. We are not doing that much aggressive strep testing on the patient. So I wonder whether it's a true increase or whether it is just increased testing that led to higher diagnosis. And so, I mean, since it's not common practice to use antibiotics early on in routine pediatric practice, you want to, unless strep is positive, of course. But a lot of times when families call the pediatrician on the phone, you give some advice on the phone and other things. You don't recommend routine strep testing right away. But patients like this, and my friend's daughter who died, a 30-year-old girl who died, I worry that maybe we should be more aggressive in strep testing patients, and this can be a deadly disease, both in sickle cell and non-sickle cell patients,
Yeah, I think, for such kind of change in practice, you need some big data that
Big data.
supports either approach. But we have not been doing more strep tests than before. We are still following the same kind of guidelines, because still, even if you have severe cases, if they're just very sporadic, it may not justify doing strep on all of the patients who are like viral illness, because this may not be cost effective. But for the sickle cell population, given that they are considered immune deficient by nature, we may need to be more vigilant about catching up early bacterial infection and treating it soon. So it may be applicable for sickle patients for such practice. I think it's really justifiable if patients have other symptoms of strep infection, sore throat, high fever without a lot of coryza, without a lot of runny nose, then this is suggestive of possible strep infection in the throat that can go to the lower airways and cause severe infection.
Thank you. They're great comments. Thank you all.
Any other comments?
I
All
have
right.
a question.
Oh, yeah.
Does these two have the clots in the jugular vein and the carotid artery? And how long are you going to be keep on the Xarelto?
Yeah, I don't know the question to that. I just let her be for now, because I don't know. I could stop it, but I just let it be. Prophylactic and treatment dose were the same, so I just let it be.
Mm-hmm.
I don't know. Anybody can help me here to do something smart in terms of my analysis and decision making.
And it's how long that the
6
patient's been
months,
on?
6 months, and she's still got an occluded jugular vein, completely occluded. And we did a hypercoagulable workup. I don't think anything stood out, but I think from all the guidelines I have read, she's okay to come off anticoagulation. Of course, sickle cell disease itself is a prothrombotic state. But I don't know. I'm sort of waffling.
Yeah, I mean, that would be the question, right? Come off and re-image and see where you're at.
It's completely occluded, so I don't know if it's been multiple ultrasounds,
Right.
6 weeks, 3 months, 6 months, all completely occluded. So yeah, maybe that may be the way to go.
Yeah, and as you mentioned, this patient will be at high risk of developing pulmonary hypertension in the future. So because that will be another reason. If the patient have evidence of pulmonary hypertension on the echo or BNP, she may deserve an imaging with CTA to look for pulmonary thromboembolism. And if there is a active pulmonary thromboembolism, she may need to stay on the Xarelto indefinitely or for a longer time. But if there are no other risk factors, she's doing well. I think we can just follow the guidelines.
Yeah, I think that's a great point. That's why I want to plan to finish the workup on pulmonary hypertension. Yeah. Thank you for that.
Would you do the surgical embolectomy or something like that?
This far out, I don't know, because 6 months is pretty scarred.
Yeah, yeah, that's true. Yes.
Yeah, so.
Yeah.
All right. Well, thank you again for a fantastic presentation and excellent case, and look forward to seeing you next time.
Thank you all. Bye.